like to introduce Dr. Alan Nye, Director of Pennine MSK. So, over to you.
Thank you very much, and good afternoon, everyone. And Paul, thank you very much for asking me to come and spend an hour on the East Lancs whilst the chickens were collected off the road. And I think all of you have got that treat if you're going back to Manchester later. So what I wanted to do, there's several parts to this talk. I wanted to spend the first 5 or 10 minutes just really underlying what I think are some of the fundamental barriers towards delivering true integrated care. And I think when you are considering sort of redesigning what you are doing, changing the way you commission or contract care, you've got to really understand what the problems are with the system as is. Because if you do it from a purely financial viewpoint, I will guarantee you will get it wrong. So I make no apology for spending some time talking around what I see as the important failures. Then I'll give you a very brief history of the development of Pennine MSK and our programme budget and prime contractor approach in Oldham, and I'll share with you some of the outcomes that we've achieved and then leave plenty of time for questions. So I don't need to tell you that these are really quite challenging times. Not only have we had the most radical transformation of the NHS, but it's being done at a time of unparalleled financial challenge. And I think something to bear in mind is that the period of time over which we developed our model in Oldham, it was those heady days of increasing NHS budgets where we actually had more money this year than we had last year, and I think that gave us a lot of leeway and freedom to develop our model, which unfortunately is basically not open to you in your room. So it's important, I think, you learn from what's gone on before. But I think there are two real problems with the way we plan and deliver healthcare. I think the first is the system of healthcare delivery. Unlike any other industry in the world, we micro-contract highly complex care pathways. We commission primary care through either a GMS or a PMS contract, and we have QOF and we have local enhanced services, national enhanced services. We commission community care through a standard community contract with Sequins, and we commission mental health with a mental health contract, and we commission acute care with an acute care contract, and they've all got their Sequins. And then we're surprised when we don't deliver an integrated care pathway. I would say with this sort of model of commissioning, it would be a miracle if actually we did commission it. And there's almost as if there is a separation of the patient, that they either have got a physical illness or a mental illness. There is no recognition in the way we plan or deliver care that patients have a biopsychosocial attitude to their illness. It affects them in the way they relate to their friends and family. It affects them mentally, and yet we do not plan and deliver care which actually looks upon people as being people with emotion and feeling, and we just do not manage that. And as a result, we produce inefficient care pathways. We also have to deal with payment by results, which I think was very much a child of its time. It was great when we had growing budgets with a drive towards achieving 18 weeks because money providers were rewarded for doing more and more activity. Now it's a real problem for commissioners because it does not give you the control around paying for quality and value. There is a set rate for an activity. And I think that is a very bad way that we now find ourselves in the way we commission care. I think there is a huge problem with payment by results. It's not a criticism of the acute trusts. They are forced to deliver care within budget, and the only way they can get money in is through PBR. But it distorts the way care is delivered, and it's a barrier, I think, to integration. And I think also there is a fundamental lack of getting to grips with performance managing clinical pathways. We tolerate variation and poor performance. And I'll give you give you some examples of that later. We also, I think, do not have true clinical leadership. We often pay lip service to clinical leadership, and if we ever are going to get integrated care pathways, I think we need to allow our clinicians not only to have real clinical leadership, but actually sort of achieve this joint responsibility where they are not just taking responsibility in the clinical sense, but they also have a degree of financial accountability for the delivery of care. We have a separation between clinical and financial accountability, and I think that is another barrier towards delivering integrated care. And the other problem is the paternalistic model of healthcare delivery. When I went to medical school, which was an awful long time ago now, I was taught when I've got a patient in front of me, I take a history, I do an examination, I may order some tests, I'll hopefully then come to a diagnosis and then prescribe a treatment. There is no engagement in the patient that they actually have an active role in deciding what's right for them. It's as though that they are a passive giver of information and then they receive and follow the diagnosis and the prescription of how to get better. Life is just not like that. The vast majority of clinical decisions are what we would call preference sensitive. So there is more than one viable option for patients to choose. And we do not empower patients either to make options which are right for them as individuals, and we do not allow them to actually take meaningful control of their long-term conditions and actually lead their own care themselves. And this is just plain inefficient. I think patients are the biggest asset we have, and it's one that we do not give them anything like the right respect and the responsibility when it comes to planning and delivering their care. So, how do we typically plan our care pathways? I think this really tells us how we do it at the moment. We actually start either from the clinician or the provider, and then we work back to the patient. So we plan our services around the needs of our providers and clinicians delivering care. And what we don't do is start with the needs of our patients and what's right for them. So we actually are looking, I think, down the wrong end of the telescope. We need to take a step back. We need to think what is right for our patients and design the services that are right for them. And I think you will find, surprise, surprise, they'll be right for the clinicians as well, and they'll be right for the organisations, because the whole system will begin to work more efficiently. Does anyone care to take a guess what this drawing is about? What does it show? Well, it's very close, actually. It's actually a hospital outpatient department. It's 1760, Central Westminster Hospital. And I think you could recognise it for what it is. You know, more than 200 years have gone past, and it's patients being dragged into a difficult to get to. You're sitting, waiting. It's organised around the institution and the clinician. And we're exactly the same now. So, are patients happy with what we're doing? Not at all. This is the results from the National Patient Survey of patients who spent at least 24 hours in hospital, and they were asked, do you want more involvement in planning and delivering your care? Half of patients say yes, they do, and it's flatlining. We are not actually making any impact on empowering patients around planning and making decisions around their care. And this study came from a really interesting review of the National Joint Registry, where they asked over 9,000 patients who had had a knee arthroplasty at least 6 months after their surgery, whether they were satisfied or dissatisfied with having had their knee arthroplasty. This is a £5,000 operation. It's not a small cost to us. And about 18% of patients were either ambivalent or dissatisfied with having had their surgery. Why do you think that was? It is. It's about expectations. When many patients have a new knee fitted, they almost think they're going to go back to their pre-disease state. And the reality is they're not. No matter how successful the operation, they will live with a degree of disability because of their knee arthroplasty surgery. And unless they understand what the likely outcome is from surgery, they will be dissatisfied and a further consumer of health resources. If you look at complication rates, about 2% of knee arthroplasty operations have some sort of long-term problem. But 18% of patients being dissatisfied, we really are doing something wrong, aren't we? And if you look at variation in healthcare, I took this from the very latest Atlas of Variation, and this is variation in the request of DEXA scans. For the non-clinicians, DEXA scan is a screening test for osteoporosis. It is robustly covered under very modern, NICE guidance. So you would expect that if you look at the amount of DEXA scanning across the country, there would be little variation because there are well-accepted best practice pathways to cover the management of osteoporosis and what happens when you fracture. There is actually a 50-fold variation in the likelihood in CCG areas of patients having a DEXA scan, and that is once you've corrected for age across those CCGs. It is inexplicable in any other way other than the fact patients are not following best practice pathways, and it's because we do not performance manage our care pathways. So I think we've got a number of challenges. I think with these latest reforms, I think there is a lack of faith in the new system. I think from sort of grassroots GPs' perspective, there is a few very engaged GPs, but I think there are an awful lot of ambivalent GPs out there who feel under the cosh, who feel undervalued, who feel, there are more expectations for more and more work. I think we're putting greater stress on our hospital-based and our community clinicians, wanting more and more out of them for less and less resource. And I think if we're not careful, we will end up with a disenfranchised group of clinical providers. And it just does not produce good outcomes. I think we've got an ageing population. We've got a financial challenge which is stretching out for the next 4 or 5 years at least. And I think there is no reason, I just don't think business as usual is an option for us. I think we've got to start thinking of doing things in a radically different way. So let me tell you about Oldham. So for those of you who don't know the glorious Oldham from where I've come today, it sits on the northeast side of Manchester, population of just under 230,000, real mix when it comes to a population, large parts of deprivation, high instances of heart disease, diabetes, 22% from BME communities. So it's quite a deprived population. But I think one of the reasons we've been able to achieve what we have done in Oldham is that we've not been reorganised in any significant way. The people who we started our journey with over 10 years ago in the PCT at the time are still the same individuals there today largely. So we've been able to build up this bond of trust between us as a clinical provider and the people working in the CCG now who are commissioners. And I don't think you can put too much of a value on the power of relationships between provider and commissioner. If you have this we're in it together attitude and you're going to work together to get the best value, then I think you can get success. And I think that's something where nowadays where we have to go through these very formal procurement, I think it's really hard to foster that. And I think it's a real challenge, I think, for the commissioners in the room to actually establish those trusting relationships that you actually produce better value because of them. So, Pennine Musculoskeletal Partnership, it began as a triage service for rheumatology in 2002. I used to work as a clinical assistant in rheumatology as well as working as a GP. And the PCT at the time asked me and a nurse consultant to set up a triage service in rheumatology. So we did. There was no procurement, there was nothing else. We just came to work one day and we were running this triage service. So we had a compulsory triage of every GP referral to rheumatology, and we decided whether the patient needed to go straight on to the consultant or whether there was value in us seeing them in the community clinic. And then we had a maximum of 2 appointments to see the patient and decide whether the patient could go back to the GP or needed to see the consultant. And it was incredibly successful. We reduced the number of patients needing a consultant opinion by 50%. So our acute trust had an enormous waiting time problem in rheumatology, so everyone was really happy with the service. In 2005, the PCT asked us to take over the running of a failing orthopaedic Tier 2 service. And so we were told we would have to go through a competitive tender. I'd never heard of a competitive tender in my life. And so the PCT asked me to submit a business case. So I wrote a side and a half of A4, and that was the business case. And surprisingly, the PCT accepted it, and we went out to competitive procurement, and we were the only bidder. So I've looked back, and as far as I can find, that we were the first procurement for clinical services in the NHS. And thank goodness, because I think nowadays they would have been swamped with lots of applications. Even though we did go through a competitive procurement, I think it has to be in inverted commas. So we went live in early 2006, and we were given a 3-year contract, and it was described under a service level agreement, and we were awarded what's called a specialist PMS contract, which means we were, from a legal viewpoint, a GP practice, but the specialist bit means there was no requirement to provide core GP services. So effectively, the services we provided were described by a service level agreement, and the service level agreement simply said you can deliver all of the out-of-hospital services for rheumatology, orthopaedics, and musculoskeletal pain. And so with this gloriously woolly and ambivalent sort of service level agreement, we've been developing our service right up to this present day. We are still growing and developing it even now. And so our ambition was to completely shift rheumatology out of the hospital into the community, and was to actually give patients the offer of being listed for their surgery from the community as well. And so what we have done, in about 3 or 4 years ago, the PCT actually decommissioned hospital-based rheumatology. We already had a couple of consultants working with us at the time, and then the remaining consultants and nurses were tupied into our service 3 years ago. So for the last 3 years, we have delivered the entire rheumatology pathway, unless the patient is admitted into a bed. And we had 6 patients last year who generated a PBR tariff. All our rheumatology payments are covered under a local tariff arrangement with our PCT. And the local tariffs are based on actually reducing the number of steps. So we've developed tariffs around treatment, around rapid discharge, around producing self-management plans, around self-referrals. So we've got a load of unusual tariffs which you wouldn't sort of recognise yourself, which basically reward development of a very patient-centred and integrated pathway. We work with about 5 different providers for orthopaedic surgery, so we are able to offer choice. So the vast majority of patients are seen. If they are listed for surgery, then they see a consultant within our service, and then the first time they go to the hospital is when they actually go in for their operation. Some 3 years ago, when I was working in the Department of Health with Steve Lakener, a long-term colleague and friend of mine, Steve had been badgering me around this concept of programme budgeting. And for the first few months, I thought he was completely bananas, but gradually the idea began to grow on me that actually it was a really, really good idea. So we put another business case, probably about 2.5 sides of A4 on this occasion, into our PCT to say we thought there was an extra value if they actually gave us control of the programme budget, and we would act as an accountable lead provider covering orthopaedics, trauma and rheumatology. And to our amazement, again, the PCT said yes. And so we went and developed quite a complex risk share agreement of how we would manage this programme budget. And it's been, I think, extraordinarily successful. I think what programme budget commissioning does, it actually gives you a budget and a defined population, and it becomes then your responsibility to deliver the best value you can, and it allows you freedom to think outside of the box and to develop care pathways that deliver that outside of the constraints of the traditional care pathways. The Commissioner moves away from process-driven key performance indicators and sets very strategic, high-level outcome key performance indicators. For example, we've got key performance indicators now around keeping people in work, around smoking cessation, around participating in shared decision-making. We have to measure how effective we are in self-management as well. And even though these are quite novel and new key performance indicators, our Commissioner is actually much more happy because I think they see this as being real value for delivering health care. And the actual fact that we now share with our Commissioner a common goal to deliver high-quality care, but within a fixed budget. The risk share agreement, we've changed slightly, and what we couldn't do as a very small organisation is actually accept financial risk for the programme budget. And we felt very uncomfortable about accepting financial risk for two reasons. Firstly, if we overspent, we could go bankrupt, which is never a comfortable thing. But secondly, if you actually make savings from the programme budget, and there is so much waste in the system, it's not hard to do. What we didn't want to do is actually be in the situation of pocketing those savings. And if you transfer all the financial risk to your accountable lead provider, the other side of the coin is that they will keep the savings from the budget. And we did not want that. We wanted any savings from our programme budget to be reinvested back into patient care. So our risk sharing has been purely around some sequin measures. So we've been incentivised to deliver integrated care, but the maximum risk benefit for us has been one of our sequin measures. So it puts a very tight envelope on how we can profit and the risk we take from delivering programme budget. And that's different to many of the other programme budget projects which are being done at the moment. So the prime contractor sits in the middle of the pathway and takes responsibility for ensuring value is delivered both back into primary care and up into secondary care. So we monitor GP referrals, we look for variation in referral rates, we provide training and support for GPs, and we go into particularly high referring practices and do case analysis with them, and that is again one of our sequin measures to actually train GPs to hopefully refer less. We get rewarded for integrated care, for delivering shared decision-making, for delivering self-management. And we insist from our acute providers that they deliver enhanced recovery principles wherever possible. So that's around day of surgery, admission, rapid discharge, etc., etc. It's not rocket science, it's really just common sense. But it allows us to actually do this and actually be fairly rewarded for doing this as well. So our programme budget when we set it off was some £23 million. Over the years, that's dropped down. It's about £21.5 million now. We've been able to deliver £1.5 million worth of savings in the past 3 years. So not an insubstantial sort of saving against our programme budget. And we put everything we legally could put in it. So that's the entire acute spend, all the community spend, and the local enhanced services. We couldn't put anything from the core GP contract in it. That is legally very separate, particularly now it sits with the local area teams. So we're now, I think, rewarded to performance manage the entire care pathway. We invest in shared decision-making and self-management support. We work with primary care to reduce variation. We ensure secondary care delivers best value and best practice, and we work with our commissioners in a very cooperative way to actually modify the contract almost on a quarterly basis. So we change it very, very regularly. And I think rather than any other model, it actually delivers integration. It actually delivers better value for money and better patient experience as well. However, it is not easy to do. And I think one of the crucial differences with what we've done from some of the models which are cropping up elsewhere is the fact that we've had time and space to develop our model. We've been doing this now for 7 years. And I think whilst you can certainly shorten that journey, there is still a steep learning curve for anyone to actually be an accountable lead provider. I think it's quite challenging for acute trusts because when you think about reinvesting along the patient journey, the vast majority of that money is realised from the acute trust budget. What you are doing is shifting money away from the hospital to invest it in both community, primary and self-care and prevention. And so there is a squeeze on the acute trust budget, which is a challenge, as it would be for anyone at all. I think you are now working under quite different financial constraints than we were working with when we developed the budget. And I think you need to get your GP commissioners on board. There was certainly some initial suspicion when we set up the service back in 2002 and again when we grew in 2006. But at the end of the day, what GPs want is they want their patients seen quickly and managed rapidly and with a good experience of care. And if you deliver that, we've had no problems, we've had no negative feedback from our GP colleagues. So what I want to do is just give you some very highlights of where we are. So an example of where we've implemented shared decision-making. This is a schematic of our knee pain pathway. If a patient is referred by a GP with what on the basis of the letter sounds like knee osteoarthritis, every referral to us is triaged within 24 hours. If it appears as though the patient has knee or hip osteoarthritis, the patient is written to and told to use one of the NHS online decision aids. If they have not got online access, we give them the offer of coming in a couple of hours early for their appointment, and we will go through the decision aid for them if they want. So they can be prepped about their condition for that first all-important face-to-face appointment. Once they see an extended scope physiotherapist, all the diagnostics are done. If the decision is that they will need surgery, they are usually seen and listed by week 7 of their journey. We are about 99.7% compliant with 18 weeks in the orthopaedic pathway. So it is possible to actually deliver care very rapidly. We decided we were going to really quite rigorously implement shared decision-making, and one of my other roles was to work for Aqua as clinical lead for shared decision-making, so I was in a good position to do this. So with the support of NHS England, we decided to do a project where we would try and measure the impact of shared decision-making in our knee osteoarthritis pathway. So we looked at the year, looking at PROMS data for the year before we implemented shared decision-making. Then we implemented shared decision-making over a 2-year period, and we looked at the PROMS data as we implemented and after we had implemented shared decision-making. And I'm just aware of the time, so I'm going to skip over that slide. And what we actually found was that patients decided to have knee surgery later, so their preoperative PROMS scores went up. But they actually reported, and it was statistically significant, a greater health gain from their PROMS data. So patients felt as though the surgery had helped them more because they had been through a shared decision-making process. The actual surgery has not changed at all. It's what is described and what the expectation about that surgery is. Patients also choose surgery not only later in their pathway, but less often. So we've seen about, just read that. I think it was a 4 or 5% growth in knee arthroplasty rates compared to about 8% across England as a whole. So patients quite happily choose to have conservative treatments as opposed to having interventional treatments. And if you look at a quadrant analysis, so the first quadrant analysis, this is for knee arthroplasty, 2009-10, we were in the high spend but better outcomes, and now we've moved into lower spend, better outcomes. So actually you can see a real shift on our quadrant analysis, and I think by implementing shared decision making. And if you look at the impact on our per capita musculoskeletal spend, it's dropped from £98 per head in 9-10 down to £86 in 11-12. So we've seen a 3-year drop in our per capita musculoskeletal spend, and that completely bucks the trend for England average and SHA average as well. So I want to leave you time for questions. I want to thank my colleagues in Pennine MSK. It's not just about me. There's a huge team of us that have delivered this. Also, I'm really grateful to Steve Leitner for the original programme budgeting idea, and I've pinched quite a few of his slides as well, which I'm always grateful for. So thank you very much indeed.
Okay, any questions?
Thanks, Alan. This really revolves around one of the comments that Paul made at the start, which was about the importance of dialogue with commissioners and providers.
Yeah.
Now, historically, you've had an advantage insofar as that dialogue has gone on over a long period of time without competition.
Yeah.
What are your thoughts about trying to pursue this in the current environment with any qualified provider, competition requirements, etc., etc.? It just feels a little bit like this type of experiment to produce the goods that are on show here now are going to be a bit more limited in the current environment. And how do we get across to commissioners that we need the opportunity to get that dialogue going to provide better outcomes ultimately for people?
No, I think that's a really good point, and I think I think commissioners need to understand procurement law very precisely. There is no reason why you can't have a really open, honest dialogue up to the point of a procurement going live, and then you've got to be careful how you sort of dialogue with potential bidders. So there is definitely a limitation, but up to the point of a procurement going live, there is no reason why you can't have a really good dialogue with potential bidders and local providers. At the end of the day, the vast majority of people delivering these services are going to be the local providers through one form or the other. It's not as if there's a huge excess of other providers. There's so much work out there. The shortage is in the people to do it, not in the sort of the threat of sort of outside competition. I think the other real challenge now is around commissioners potentially seeing this as a way of limiting their financial risk. And really, it can be, but the biggest advantage, it's a way of delivering better value and better outcomes for their population. And I think the financial risk needs to be shared and not handed over, because I think you will end up with worse outcomes if you do that. So it's around the commissioners, I think, being brave enough to actually think about this as a model, to actually do their groundwork before they go to procurement, to develop their local market, and then go and do it. Give it a shot.
And actually, it covered pretty much what I was going to say.
But actually, you are now involved in both in providing something in Bedfordshire
Yep.
and in bidding for something in Sussex.
Yeah, so I mean, our business has grown exponentially, and we decided many years ago that what we never wanted to do was to actually geographically grow. So we've got no interest in delivering musculoskeletal services outside our patch, because I think one of the things that make us successful is the fact we are of a certain size. And I think if you start to grow and grow and grow, you lose what makes you special. But what we do is provide support to either other clinical providers to bid for and develop these models, or to commission us to actually commission them and develop a commissioning spec and outcomes framework. So that's how we now sort of spread our word now, Paul, but not in actually seeing patients anywhere else.
Hi, Alan. That was a really good demonstration of how integration can work in a particular field and a particular scale. I suppose, what was your view on transforming community services, which really was supposed to enable much wider and greater intervention, integration to enable such things like this and whole pathways of care to actually happen? Do you think that TCS has helped or hindered the whole integration process, especially when we're looking at stability, relationships?
I think I think it's a really difficult question. I think there have been some good things from removing the sort of slightly schizophrenic approach PCTs had of both providing and commissioning care. But again, what I think is potentially quite harmful is the fact that there are some CCGs who see the need almost to recommission every 3 years. And I think if you're not careful, what happens is that you're almost... You sort of build up to a tender, you win it, you've got a 3-year window, but you're only actually doing things for 2 years, and then you're building up again to the next tender. And I think that is just so destructive around relationships and long-term planning. So I think it's a bit of a curate's egg, really, TCS. I think there are some... I think it's an opportunity to change, and I think if somebody is retendering their community services or have been through a process, it's often a line in the sand to say that we don't want to buy what we've had for the last 15 years. We want something very different. So it's a really good point to take stock and think, am I going to do something different? But if you're not careful, it can also be destructive as well towards building those relationships and integrated care.
I suppose I'm thinking that those organisations that went into the acute, it was always that we didn't have community services, so therefore we can't change the pathway, we can't make those significant changes. And I'm just wondering, is there anybody in the room has got the evidence where that has been effective, where we've broken down that community acute barrier?
I'm not personally aware of any, but I wouldn't be the man who would be aware. I don't know whether anyone else in the room has.
I don't think there are many, and maybe none, where I know Durham County quite well. So Durham Hospital was a medium-sized hospital, took in community health service, which were about the same size in money terms, but I'm pretty, well, it isn't integrated. It's two organisations. And so I'm mainly quite disappointed how, so where my local area in South London, Guys and Tommy's enormous, takes in Southwark community services, and it really isn't integrated. It's as if the acute organisation, I mean, earlier on I was talking about mental health trusts, where it took them probably 20 years, again, to actually do that relationship of inside an institution and outside an institution. And I think most places are still two businesses.
It's just an opportunity I feel we might have lost in that sense to aid integration.
Just to add to your question, I'm actually here from East Lancashire, and I'm based within the Hospital Trust, and we've just become an integrated care group. Community Services was in the Hospital Trust for quite a while, but now we've actually got a management structure across acute and community services, and it is phenomenal, the difference in the working structure and culture that started to happen in the organisation, and we've only been operating about a month, but it's amazing, yeah.
So I think what's interesting is sort of 2 years ago people joined up and thought, what on earth is all this about? And the general trend about integrated care has made some organisations think, well, obviously this is what it's about. We've wasted 2 years and now let's go on with it.
I think there might be one more question.
If you're looking around organisational integration, or you're looking about services being person-centred and family-centred, and maybe we concentrate and focus too much on organisational change.
I think it's looking down the wrong end of the telescope again, isn't it? I don't think you need to integrate organisations. I think you can easily get lost in management structure, to be quite honest. It's integrating the care. It's in getting the clinicians to work together, and the management structure enables that to happen and the financial flows to go. So I really, we've not integrated any organisations to deliver ours at all. So I don't think you need to go down that route. It's too simplistic. It's like merging a failing trust with a successful trust. If you're not careful, you end up with a big failing trust.
Sorry, I like to have the last word. What I was going to say was, it is I suppose really just extending that is acute and community might not be the right organisations when the majority of the needs for people are social care. And I'm saying that from a health professional, but she's influenced me. And whilst I don't disrespect that they have got clinical needs as well, the majority of the needs that people have that keeps them well emotionally are the social factors. And I think maybe the integration, that horizontal across health organisations, isn't possibly the right way.
Well, I'll just have the last word if you don't mind as well. And I think
I'll have to come back to me then.
I think one of the easy wins for us was in doing this in a condition like musculoskeletal, where there are a lot less social needs than if you did a frail elderly pathway. But I think the real benefits from this way of working are actually doing something like a frail elderly pathway, because there is such waste and lack of integration in managing frail elderly patients. And I think if you had an integrated health and social care budget along the lines of our programme budget, you could really do some really quite exciting things.